Good afternoon. Thank you for joining us for the Oley Foundation webinar, Practical Management of Home Tube Feeding, generously supported by AVANOS. My name is Andrea Guidi. I am the Executive Assistant for the Oley Foundation. Most of you are probably familiar with the Oley Foundation, but just in case this is your first experience, I'd like to briefly introduce the organization. The Oley Foundation strives to enrich the lives of those living with home nutrition support, both intravenous nutrition, sometimes called HPN or TPN, and tube feeding. We do this through education, outreach, and networking. The Oley Foundation was founded in 1983 by Dr. Lynn Howard and her patient Clarence Oley Oldenburg. Today we serve approximately 20,000 members. All of our programs are free of charge for patients and their families. First, we'll go over a few housekeeping details. You should see a toolbar on the right side of your screen. Click on the orange arrow to show the control panel. In the question section, you can type any questions you have for me or for the presenter. Please note we will not be responding to the hand-raising function in the control panel. We will answer as many of the questions as possible during the question and answers period at the end of the presentation. We'll post a recording of the presentation and handouts after the webinar on the Oley website. Please note that we have muted all of the participants, so you don't need to worry if there is background noise where you are taking this webinar. If you are having technical issues, please go to the Citrix website at the address on your screen. Now for the presentation. Sometimes home tube feeding presents challenges that can interfere with the consumer's relationship with their tube and tube feeding experience. This engaging presentation will review several common complications with tube feeding and tube site care that can be addressed with simple strategies and appropriate clinical guidance. Cynthia will illustrate best practice solutions in the form of case studies that review symptoms, possible causes, recommended solutions, and strategies for prevention. It gives me great pleasure to introduce today's presenter, Cynthia Reddick. Cynthia has worked in home tube feeding for the last 20 years, working to facilitate tube feeding patients' successful transition from hospital to home while providing positive clinical outcomes. She developed her passion of nutrition support during her internship at the City of Hope National Medical Center in Southern California and continued to develop her expertise with experience at major teaching hospitals such as Cedars-Sinai in Los Angeles and UC Davis Medical Center in Sacramento, California. She is the National Tube Feeding Manager for Coram CVS Specialty Infusion, where she has worked for 12 years and has presented roundtables and clinical posters at Aspen and NHIA, webinars, and case studies in the area of home care tube feeding. She has been a guest lecturer for the Oley Foundation, hospital and insurance case managers, physicians, registered dietitians, registered nurses, and social workers on a variety of topics related to home tube feeding. We are thankful to have you presenting today. Cynthia, I will now turn the presentation over to you.
Thank you so much, Andrea, for that wonderful introduction. I really appreciate it, and I'm very excited to be here with you all celebrating Feeding Tube Awareness Week and talking about tube feeding, which is one of my favorite things to talk about. So I will preface this presentation with a small disclaimer that there are some photos in here that are not as pretty as the one that you're looking at, but I did change my style a little bit, and I'm starting the presentation with a pretty picture, and I will end the presentation with a pretty picture, but everything in between is all for learning. So let's begin. First of all, I have no conflicts of interest to report. I have no financial or non-financial relationships to disclose. I will not be endorsing any products. I will be talking about some products in an educational manner, but I will not be endorsing any. And this information is presented on the best known clinical evidence in addition to what I refer to as experiential data. So what will we be covering today? So I'm going to start with some storytelling. I've got a couple of people that I want to introduce you to. I refer to them as Debbie and David, and I like to tell you their story because I learned many things in their stories and their experiences that I want to share with you. Then we'll talk about setting yourself up for success and making your tube feeding regimen work for you at home. What was prescribed in a hospital setting doesn't always work for us at home. So we'll talk about some different strategies that way. You do have options at home with regards to what you're feeding and how you're feeding, so we'll cover that. And then finally, your tube feeding shouldn't hurt, and so we'll be identifying and solving some tube site complications through case studies. So to begin, as a clinician who cares for patients on tube feeding, one of the things that we do is check in on a regular basis to check on tolerance. When folks are at home on tube feeding, we want to check tolerance related to diarrhea, nausea and vomiting, abdominal bloating, cramping, any GI intolerance issues, and that's a standard across the board. But one of the things that we began implementing several years ago in the care of our patients at home is identifying tube-related issues. And so that's something that we screen for now, just looking at problems with the tube site that may interfere with a patient's relationship with their feeding tube. But the concern that I have developed over the years is that I have found a lack of clinicians that are familiar with the monitoring requirements and how to, more specifically, how to treat the complications at the tube site. So that's where I want to lay a baseline of what's normal, and if something is not quite right, then to advocate for yourself and work with your tube feeding tribe of clinicians to help you solve those problems so that you can improve your relationship with your feeding tube. So this is a great picture. This is one of our Oley ambassadors, and he was kind enough to let me photograph his tattoo several years ago. This is somebody who proudly represents a healthy relationship with his feeding tube and his lifestyle on tube feeding. And I love this because I share this picture with clinicians as well when I do teaching, because I love the message at the top, which is do not overfill, which we're going to talk about. That was sort of a wake-up call for me, that some folks tend to overfill their reservoir, so to speak. But he's got a great sense of humor, and he advises folks not to hike behind him on a trail. Okay, let's move on and talk about Debby. So Debby is a consumer who entered my realm with this problematic tube site that was a generic complaint of a leaky tube. And that's a tricky one when you're dealing with somebody remotely to figure out what exactly is leaking. So we're very frequently will troubleshoot with the use of pictures and things of that nature. So when she sent her picture, this is what we saw, and there was this, it didn't capture the actual leaking that was occurring, but it showed the result of that leaking. And so there's this gooey sort of mess around her tube site. It was red and inflamed and not comfortable. It was very painful. So I worked with her. I sort of took her on and worked with her on this case study because it grew into something bigger and more profound for me as a clinician, and I'm happy to tell her story. So I met with her and worked with her on her tube feeding regimen. And what I found was that she was feeding 2 cartons of formula per day, 2 cartons of formula per feeding 3 times a day. And when I met with her and observed her doing her feeding, she demonstrated something I had never seen before. And I'll refer to it as power feeding. She would draw out the syringe of formula and push it through her feeding tube so fast it made my head spin a little bit. So I slowed her down. We stopped after that first feeding, and she sort of talked me through the rest of her regimen. And what I found out was that she was feeding too much volume in one setting. She was feeding what was equivalent to 1.25 liters of formula plus water and a little bit of Pedialyte. She had this regimen where she would do a little Pedialyte, then her feeding, and then a whole bunch of water after her feeding. And it measured out to this large volume. So I showed her what that looked like in a measuring bowl or a mixing bowl, and held it up to her stomach and showed her how much liquid that was. And she had never really looked at it that way. She just knew that she wanted to get through this feeding and move on with the rest of her day. So what she said to me was that she didn't have time for this watering and feeding. And those were her words, and that's how she described it. So I don't have time for this watering and feeding. And so she would power feed and power flush to the point where she was overfilling her reservoir. And that's what was causing the leaking, because when I looked at her tube, and you can see it here, it was fitting kind of snugly, a little bit too tight actually. And so I couldn't, assume that it was just a improperly fitting tube or a tube that was too big and it was leaking because of that. She was actually overfilling her stomach. So we went about a process of negotiation at that point where we worked out a feeding regimen and a flushing regimen that was reasonable for her size and spaced things out a little bit, but it had to fit her lifestyle. So we talked through that and made a plan for that. And then we also worked on her tube site with regards to what was a yeast infection. That's what you're looking at there. And I'll talk more about how we solved that problem later. So that was Debby. Now I want to introduce you to David. So similar timing in my life, these two sort of crossed my path, and I learned so much from David as well. He was struggling with his tube site, did not have a healthy relationship with his tube. He was complaining of this ooey gooey mess sort of at the tube site, and you can see a picture of that there on the top right. He had what's called hypergranulation, and you can see that on the top left. That was the cause of that ooey gooey mess. His tube wasn't fitting quite right. It was leaking. He was also overfilling and feeding too fast. And so his tube would leak and his tube was too large for his stoma. So he also showed me the different things that he was using to try to treat his tube site. And so that was a picture of his triple antibiotic ointment that he was buying at his local pharmacy. He was using a sterile alcohol prep swab, which is not appropriate use for a tube site, but that's what he was using to clean. And so that was another cause of the hypergranulation that was going on in his tube site. And he was using a lot of gauze. So that's a picture of his gauze where he was using lots and lots of that to keep things clean. The other problem that he was having, because he had this poor relationship with his tube, he was not compliant with his feeding regimen. He needed to gain weight. He was very thin, but he wasn't meeting his goal because he was having this leaking, and he was also having a lot of reflux and this foamy reflux where he was constantly having to spit into a napkin, and it was getting in the way of his life, and he wouldn't leave the house because of it, because he was so self-conscious of it. So he was not in a good place in his life because of these complications and his relationship with this feeding tube. So we went to work to solve some of these problems, and I'll just talk you through our journey together and what we did. We worked together to change from he was on a 1.5 calorie formula, and so we moved him over to a 2 calorie formula. He talked to his doctor about using a medication to work on that reflux, so we had a conversation about the risk versus the benefit of this medication, and they decided to move forward and try what's called a prokinetic agent, and basically it's like an anti-reflux medication. And then he liked to blend his own food as well. He was a chef in a former life, and so he wanted to blend his own food again and start feeding that. So we did this combination of his formula, which gave him the bulk of his calories, which he needed, and what I would refer to as 10 cubes a day, because he would blend his own food and freeze it in ice cube trays. And we talked through the ingredients of that, and we made it a low protein blend because he was already maxed out on his protein from this formula. And it was something that he just really enjoyed doing again. So the combination of the calorie increase from the formula, in addition to the extra calories from his blended foods, and getting back into compliance with his goals, in terms of how much he was taking in a day, he was able to gain weight. And the anti-reflux medication was a game changer for him, because it changed everything about his ability to move forward and actually meet his goals every day. And what you're looking at here is his journey back from malnutrition. He was 135 pounds and very underweight. And you can see his journey as we progressed slowly over the next few months back into finally his target weight and what he was shooting for. So that was a really great outcome. And we also worked on his hypergranulation, and I'll show you how we did that a little bit later. But first I want to talk about formula selection. When we are in the hospital, you're sort of limited to different options, what the hospital has available. And when you come home from the hospital, all of the options open up. And so these are your options at home. There are standard formulas. There's hydrolyzed protein, which is like a the way I describe it, it's like a pre-digested formula where the proteins are sort of broken down into smaller elements so that your intestines can absorb them easier. There's disease-specific formulas, diabetic formulas, renal formulas, pulmonary formulas, etc. And then, of course, blenderized formulas. There's commercially prepared, and there are home blends that folks do. So there's a lot of options. And with the standard formula, what we did with David was we moved him from this 1.5 formulation over to a 2-calorie formulation. He was on a standard formula. And that was a great option for him because then he didn't have to use as many cartons a day to meet his goal. Nowadays, in the standard formula category, we have organic and plant-based options available. Not all hospitals have these options available, but when patients come home, it may be an option for them. Hydrolyzed protein also comes in a different caloric densities, and there is an organic plant-based option available for that. And then in our blenderized group, there are commercially prepared options that are meat-based, plant-based, there's organic, there's non-organic, there's multiple different options out there. And then there's home blend. Some folks will do a combination of a home blend in addition to a commercially prepared formula option. The next thing you can look at is your feeding method, because what worked for you a year ago may not work for you now, whether it's because of your lifestyle change or your tolerance changes. You may have improved your tolerance. Sometimes, children who are growing up and improving their tolerance and maybe can take a more active role in their feeding. Those are some of the changes that occur. So think about different options with the way that you do your tube feeding. So bolus or syringe feeding is a very common feeding method, and you can see it demonstrated here. This is what I refer to as the funnel method of bolus feeding. So although she's using gravity to let the formula flow through, we do still refer to this as bolus or syringe feeding from a supply perspective. That's how we differentiate what sort of supply somebody needs for their tube feeding. So this is bolus feeding, and the benefits are that, it can be timed to be, more like eating times, and it can be assimilated into the family lifestyle. It may be less time consuming. Hopefully you're not power feeding to make it less time consuming. There's no real special equipment needed, although some folks don't tolerate bolus feeding. So those are some of the potential disadvantages, is that you do have to have good GI tolerance and can handle larger volumes, and you need to be able to manipulate the syringe and have good dexterity. So these are all things that we keep in mind when we're putting together a home care plan, a home care friendly plan for somebody going home on tube feeding. And of course, bolus is not indicated for folks that are feeding into the small intestine. Gravity bag feeding. So when in home care, when we are preparing somebody for their supplies and delivery at home, gravity feeding implies the use of a gravity bag and a pole. And so all of these things are required from a supply perspective. So think of gravity as an option. I think it's an underutilized option. It's sort of a hands-free way of bolus feeding, in my opinion. So you can pour a specified amount of formula into the bag, and then there's a little roller clamp on this gravity bag right here that will let you control the rate. And so although you can control the rate, you can't make it as specific as a pump, but it's a great way to mimic a pump if you don't need a very specific feeding rate. And again, this is not generally indicated for feedings into the small intestine. Now, there's an innovation that I want to talk about referred to as the Bfed delivery. Newer product that is available for patients in the home setting, depending on your home infusion company or your DME company. That is one of the potential disadvantages, is that it may or may not be available with your local infusion provider. but and there's a lack of familiarity still, so it's sort of a newer innovation, and there's a lack of familiarity with some prescribers. But this may be a really nice option for somebody who wants to have a little more portability with their feeding. It's coded as a gravity feeding method from a billing and insurance perspective, so it doesn't require any special justification with regards to Medicare or with insurances. It's treated the same way from a billing perspective. It's treated the same way as a gravity feeding, but it's actually more stylistically more like a bolus feeding. So these bags are reusable, and they can be filled with standard formula. They can be filled with a blended formula. They can be filled with a home blended formula. And you can either let it drain to gravity, but most of the time it requires a little bit of a squeeze on the bag that can then push the formula through the tube. And this is an end-fit connector. So this is a really nice option for folks. So I'll tell you a story of a patient I was working with. The mom who her daughter had been on pump feedings for quite some time and had graduated into bolus. So her tolerance improved. She's getting older now, and this was a way to make the option available for this little girl to feed herself, because with the syringe it was a little bit more difficult for her to bolus feed herself. But this gave her the opportunity to get involved with her feeds and make them portable. So she moved over to this feeding method from Bolus, and I think they're doing really well on it. Pump feeding is another option. So the potential benefits of use is that you have a very controlled rate. And so for tolerance issues, or if you need a very specific amount infused over a very specific amount of time, this is the way to do it. It does require more supplies. You have to have some education about how to use the pump, which is not a difficult thing to do. And those feedings typically occur over longer periods of time, but you can set a pump to deliver faster feeds. Generally, the pumps go up to about 400 milliliters per hour, so you can deliver larger volumes over prescribed amounts of time, but they can infuse very quickly with a pump. All right, so let's begin talking about tube sites. Now we've covered sort of the practical aspects of how to manage your lifestyle and feeding method and the formula that you're going to use. Now let's talk about the care of your tube site and what's normal and what's not normal. So what's normal healing of a G-tube site is the G-tube or J-tube should look like this. It should look like normal, healthy skin after the first couple of weeks. This heals up any crusting or oozing from the procedure should be resolved, and the skin should not be as tender to the touch every day after a procedure. That the pain from the procedure should be getting better and not getting worse. So that's one of those things that you want to keep in mind, is that after a newly placed tube, every day things should be feeling better as opposed to the other way around. So I love this image. This sketch really shows you what a G-tube placement looks like. And so the picture on the left here, what you can see, and this happens to be a balloon gastrostomy tube. So what's in here is water, and this is what keeps the tube in place on the inside. And then this is an external bolster, and this is what keeps the tube in place and securely fitting from the outside. And what's in between is this is the stomach lining, and this is the abdominal wall. And what's happening after a tube is placed is this is pinching off and creating adhesions, basically, and it's protecting over the next 2 weeks after an initial tube placement. This is pinching off and adhesions are developing, and that's a good thing. And what that does is it protects this interperitoneal space from any formula or liquids getting in there and causing an infection. So this is a very important time after a tube is placed, and that's why it's placed fairly snugly in the beginning, is so that these adhesions develop, and there's a nice mature stoma tract. That's what this is referred to right here, is a stoma tract. And then this is just a great example with a balloon, or excuse me, with a button or a low profile device that's placed. This I will affectionately refer to as a dangler tube, like a longer dangler tube, and then this is a low profile device. So we know what normal should look like. Let's talk about when things maybe take a different turn. So PEG site infection is the most common complication. In the literature, the incidence rate ranges from 3 to 30%. And factors that increase the risk of infection are listed here. These are all things that suppress your immune system. So high blood sugars out of control, obesity, malnutrition, chronic steroid use, all of these things can increase your risk of infection. There's some research that shows that use of a pre-procedure, meaning pre-G-tube procedure, dose of a broad spectrum antibiotic can reduce the incidence rate significantly from 18% down to 3%. So when we do identify a bacterial infection at the G-tube site, what do we do? So generally, if it's a mild bacterial infection, as the home care clinician, we tend to be the ones that maybe identify these things because we're in contact with patients. Maybe we're seeing the patient doing some education. So if we identify that there's a problem, we're going to make recommendations to the physician or the prescriber who's taking care of that patient. But generally, we'll recommend a topical antibiotic, so a prescription grade antibiotic. Now, David was using triple antibiotic ointment, and he didn't even have a bacterial infection, which was the second problem in his case. But a triple antibiotic or over-the-counter Neosporin is not going to resolve a legitimate bacterial infection. You want to go prescription grade with something like bacitracin. And I do prefer topical when I can have it managed that way. But if a bacterial infection is too severe, a systemic antibacterial that is, given through the feeding tube is the better way to go. So here's a case where this lady had been living with this for about 10 months. This was baseline for her. She had had her tube for a year, and a couple months in, this just sort of became normal. And she had been working with her GI physician and telling him there's something wrong with my tube and having it replaced several times. And finally, he pulled us in to work with this patient. And what we learned was that she did not have a home infusion provider. She was sort of winging it at home on her own, buying an over-the-counter store-bought oral supplement and using that through her feeding tube for her nutrition, and was living with this ooey gooey mess for many months unnecessarily. And so what you can see here is there's some crusting, and there's this evidence of this bacterial infection, this sort of stringy discharge that was just sort of a constant thing. She was cleaning her tube site with saline, so that was something we identified as a problem. So when we got involved in her care, we did several things. First thing was educate her on how to care for the tube site with soap and water. The bacterial infection, clean with soap and water every day. And then the physician, we recommended that we get this patient going on an antibiotic, which he did. So within just a week, you can see the improvement here. This was after week 1 of a 3-week course. And then lastly, we got her admitted to our services. She had Medicare and she qualified for tube feeding coverage. And so we got her set up and we worked on a plan and put her on a better formulation that met her needs, and it was covered by Medicare. And so the last piece of this story, which is the most unbelievable to me, is that she had been bolus feeding with a 10 cc syringe for a year. She had no idea that this larger option of a 60 cc syringe was even an option. So we sort of changed her life with getting her tube site healthier and getting her, so on service with a tribe of clinicians that could help her manage these problems if they were to come up again. So we were really pleased with that outcome. This was a more severe case. Up to this point, I had never seen a bacterial infection quite this bad. And what you're looking at here is cellulitis. So this feeding tube, which actually is not a legitimate feeding tube. This is actually a urinary catheter that was placed as a feeding tube for this patient. This was a jejunal tube. I do tend to see this more often than I'd like to, but this urinary catheter, you'll notice, does not have an external bolster, so it's sutured to keep it in place. And there may be some of you on the line here watching this up recognize that this may be a similar tube that you have. There are other options out there, but this is what this patient was provided. And the other thing that you're looking at here, this is called a tube securement device. So this is something that if you have a tube, a dangler tube that does not have a bolster to secure it, you want to make sure that you're receiving a tube securement device so that it's stabilized. Now this is cellulitis, and the way that you can tell it's cellulitis is that it's this red inflamed area that you can tell is going through the deeper layers of the skin. And so when you have cellulitis, it's implied that there's a bacterial infection. So this patient needed a course of antibiotics. And that's what we recommended. So those are two pretty severe bacterial infections, but I'll be honest with you, I don't see that very often. What I see more often is what I'm going to talk about next. Hypergranulation. Hypergranulation is this hyperplasia of granulation tissue. These are very clinical terms, but you're going to get some pictures of what I'm talking about here that sort of exemplify what these clinical terms mean. But generally it presents as this spongy, fragile, exuberant mass of tissue. It's very vascular. I've never had anybody tell me that it's not, I've never had anybody tell me that they didn't notice it or that they didn't feel it. It's at minimum uncomfortable to have hypergranulation at the tube site and is usually painful. And because it's so vascular, it bleeds very easily. Now, hypergranulation inhibits epithelialization, which is part of the wound healing process. It's that part of the wound healing process that starts laying down the foundation and the infrastructure for healthy skin. So hypergranulation gets in the way of that process and really increases the risk of stomacite infections. So what causes hypergranulation? Usually I can find a cause. Sometimes I can't. Sometimes it's just the body's response to the presence of this prosthetic. But usually there's either somebody's using hydrogen peroxide or the alcohol swabs like David was using to clean his tube site, or the tube is not secured and it's moving around, like it's flopping around, maybe left to right, or it's sliding in and out of that stomacite. If that bolster is not set properly, that tube can move in and out. And that friction at the stomacite will cause what's called hypertrophy, or like an excessive amount of growth of the cells on a microscopic level. So that friction stimulates those little cells to grow this proud flesh. So what do we do when we identify hypergranulation? Well, we make a recommendation to do something, to make an intervention. I've had too many cases where the patient was told by their practitioner that it's normal to have hypergranulation at the stomacite. And I'm here to tell you that it's not. And something needs to be done about it, because if not, it will lead to other problems. So what do? We educate about how to stabilize the tube and re-educate about how to clean if they're using alcohol at the stomacite, and then start tackling the hypergranulation. And there's several approaches to this, but I will share with you my experience and my practice. And I take a more conservative route and prefer to start with hydrocortisone cream. And so that is an over-the-counter option. There are prescription grades available. If the stomacite does not respond to that, if that hypergranulation doesn't respond to that, then we'll recommend silver nitrate or debridement by cauterization. So here's an example, very classic presentation of this proud flesh. And in this case, this bolster was set back too far, and this tube was sliding in and out and in and out. And that friction right here of that tube sliding in and out is what caused that to grow. So this case was fielded by one of our dietitians who was following up with her patient's tolerance to tube feeding, and asked the question, are you having any problems at your stomacite? Any problems with your tube? And she said, yeah, it looks like part of my stomach is growing out of my tube site and I don't know what's going on. And so she sent us these pictures. And what you're looking at here is the proud flesh. So you can see it right here. there's a little clue as to how this was caused, and that's because this bolster was set way back too far. So she explained that it was moving in and out and didn't realize that that's what was causing. So this tube was moving in and out of that stoma site, and that's what grew, essentially, that hypergranulation right there. Now you might be asking yourself, Cynthia, why is there a picture of nasty gauze on your presentation? But they shared the picture with me, so I thought this really tells the story of what life is like with an untreated hypergranulation. Hypergranulation is an ooey gooey factory. It's not benign, it's not normal, and it shouldn't be ignored because it creates this mess around the stoma site, which then creates other problems, which we'll talk about. So what did we do? We recommended tube stabilization, and we educated the patient on how to do that, and instructed on how to place that bolster properly, and then did a very simple twice-a-day application of hydrocortisone cream. And when you're putting hydrocortisone cream on proud flesh, it needs to go only on the proud flesh. You should not put that on healthy skin tissue, only on this part right here. And after 2 weeks, you can see the progress. This is fantastic. So it responded really well to that. We weren't done. There was still a little bit of proud flesh in here in the stoma, so you got to get your glasses on and get a close look at what's going on in there. We still had a little bit more work to do, but 2 weeks of the application, reassess, and then in her case, we did an extra week, and that helped her. So now let's talk about yeast. So yeast infections are a fungal infection of any of the Candida species. Again, with hypergranulation, this is one of the more common things I see, as opposed to bacterial infections. This one is a little bit more common in my experience and what I encounter. So these are the clinical words that describe what you're going to see on the next slide. So pustule with secondary lesions of papules. So these look like little pimples that are either white or filled with yellow fluid, or they're just a red inflamed area. Erythema is basically inflamed skin around the yeast infection around the stoma site. Maceration is that breakdown of the slow, early breakdown of skin that's exposed to moisture for too long. Like, okay, think about a time when you had a Band-Aid wrapped around your finger really tight and you showered with it for like 3 days because you were afraid to take it off. And when you take that Band-Aid off after a few weeks and you finally look underneath it, it's kind of white and discolored. That's what maceration is. That's that discoloration and change of the skin because of the exposure to the moisture. Pruritus is itching. Satellite lesions, you'll get a look at that. Again, it looks like the red inflamed little spots around a stoma site. So what causes yeast infection is just prolonged exposure to moisture. So either the stoma's bleeding or it's leaking, or there's moist dressing that's a little bit been on there a little bit too long, and that can cause a yeast infection. So what do? We need to resolve the leaking, right? So we have to fix the problem and then treat the infection, right? Stabilizing the tube, finding ways to prevent the leaking, making sure the tube is fitted properly. And then from a clinical intervention perspective, what we recommend is barrier cream when the moisture is still an issue. When the moisture and the leaking is resolved, you can discontinue use of barrier cream. Hydrocortisone cream tackles the inflammation in that erythemic red inflamed skin. And then, of course, an antifungal. And the antifungal kills the yeast. And so you have to kind of do all three, and there's a process for that. You just kind of have to put them on rotation. Each one of these are a twice-a-day application, sort of around the clock. And I always get asked questions about how do you apply it and when do you apply it and the rotation protocol. And my biggest recommendation is to make sure if you put barrier cream around to protect the skin before you apply the antifungal or the hydrocortisone cream, make sure that barrier cream is wiped off, because that's what Debby was doing with her yeast infection. She had been treating it for months, but she was putting her nystatin on top of the barrier cream and it wasn't working. So that's my main recommendation there. So here's an example of what a yeast infection looks like. And what you're looking at here is erythema, right? This is that red, inflamed, upset area of skin. It's painful. Hers was itchy. Here's a little satellite lesion. one of those red pustule areas. And then after a couple of weeks of the intervention that I talked about with the hydrocortisone cream is going to really work on this red inflamed area. It's going to beat that down and calm it down. So when that red inflamed area goes away, you can discontinue the hydrocortisone cream. But what you can see here, after 2 weeks of intervention, the redness is calmed down, the satellite lesions are healing, but you can see the yeast on here. This is that peeling, scaly appearance that suggests yeast. And so the antifungal needed to continue there a little bit longer. But that showed you the improvement after just 2 weeks of intervention. So it was a great response. So this case presented as a bleeding stomacyte. Our first impression was a little scary, right? But once they cleaned up underneath their bolster, we could see what was going on. And so you can see two things on here. There's a yeast infection going on because of the prolonged moisture from the bleeding. You can see a satellite lesion there. You can see the macerated skin. It's got that different color. It's starting to break down. But you can see right here, if you look, get your glasses back on. If you look really, really closely, you can see that hypergranulation. And that hypergranulation was caused because this tube was sliding in and out, and in and out, and in and out. And it was, the friction was causing this to grow. And this hypergranulation, although it's so teeny weeny, it's super vascular, it's super fragile, and it created this entire mess because of the moisture from the bleeding. So we worked on this one with that protocol that I talked about, which is the rotation of the hydrocortisone cream, the antifungal, and the barrier cream. And you can see in a month and a half that it was nearly resolved. A pretty good response there. This is an example of irritated skin. This is not a yeast infection, but you can see the irritated skin because this tube was leaking. So this was one of those cases where I learned as a clinician, and I want to pass this along, this learning moment on to you, because I couldn't figure out why this tube was leaking. It's fitting really well. So I asked Mom to take the tube out and reinflate it with the same fluid, and you could see that the balloon was lopsided. And this lopsided balloon allowed fluid to leak out because it wasn't resting up against the stomach lining in a way that protected leakage. So got her in there with her fingertips all around here and to massage that balloon. So what I learned from this lesson is if you're replacing your own balloons, pre-inflate them, massage it to make sure they're symmetrical, and then insert it. This was a recent case, again, of a leaky tube. I want to show you what it looks like. There's no yeast infection going on here. The skin is not happy. This is a terrible burn from acid that was leaking out of this stomach, this patient's stomach. And as you know, gastric acid contains a lot of things and is very acidic, and the hydrochloric acid in your stomach is important. It breaks down nutrients and it allows us to digest food. It begins that digestion process. It kills bacteria and viruses that we may ingest or find their way into our system by way of our nose or the food that we eat. It also prevents bacterial and fungal overgrowth in the small intestine. And so, having an acidic environment in the stomach is a good thing, but when it's leaking out of a stomacyte onto the skin, that's a very bad thing. And so you may wonder, how is it that we don't burn a hole on the inside of our stomach from all of this acid? And there's this protective mechanism in our stomachs that protect the inside lining of the stomach with our epithelial cells. That we have these cells on the inside lining of our stomach, and they produce this mucus, and they produce bicarb, which coats the stomach lining, but it also neutralizes the acid, and it creates this physical barrier between the stomach wall and the acid that's inside of our stomach. And so there's this really beautiful thing that happens in our stomach, but when it leaks out onto our skin, our bodies are not designed to protect from this. So what did we do? We need to stabilize this tube. This bolster was set back too far, and make sure that on the inside, that balloon was resting on the inside lining of the stomach, and then set the bolster so that it's fitted properly. So what do we do when we have a case like this is you would want to protect the skin with barrier cream and then also treat that red inflamed area with a hydrocortisone cream. So here's the internal view, for instance, of what I'm talking about. This is a nice, healthy stomach. So if you remember that picture I showed you, the sketch of the tube placement, this is sort of the real life view of what it looks like on the inside. And this is a healthy stomach. And this is a balloon that's properly inflated. It is discolored, and that's normal. You probably don't get to see what it looks like on the inside very often, but this is a normal thing that occurs. There's just staining that occurs with the fluid in the tube. But you can see how this balloon rests up against the inside lining of the stomach, and that's what helps prevent things from leaking out. If this balloon were pushed into the stomach and there was a big gap between the stomach and the balloon, well then yeah, things could leak out. So in contrast, what I wanted to show you was and again, this is a healthy stomach, right? This case came up and I wanted to share it with you to show you what gastritis looks like. This was somebody that was complaining of pain when they were doing their feeding and when they would flush. That wasn't pain at a stomacite. It was deeper than that. It was more severe than that. And so I recommended that she get an EGD, a scope, so that they could get some pictures on the inside and see what was going on. Because she had a yeast infection on the outside that we were working on, but there was something else going on. And so when this picture came back, I thought this was really interesting to share. What you're looking at here is inflammation. This is the gastritis. So this is your healthy tissue, and this is tissue that's inflamed and is having a bad reaction to either H. pylori infection or either that, or it was excessive amount of aspirin or NSAID, anti-inflammatory use, but this is something that would be treated with medication to calm that down. So I thought I would share that learning with you, show you what mold looks like inside of a tube. If there's mold in a tube, it needs to get replaced. You can't scrub it out of there. Don't try. It's time to get a new tube because that tube will crack and break over time. And then this is tube degradation. This is a tube that's breaking down. This patient of ours called in, was asking for help about how do I flush this stuff out of here, because she was flushing her tube just fine. The tube would flush, but this wasn't moving, wasn't going anywhere. And so what we determined is it was tube degradation, and it was tube degradation that was related to yeast colonization. So this is another case where you want to advocate for a tube replacement. All right, so in summary, your tube feeding shouldn't hurt. My main message, you probably have figured this out by now, is build a tribe of knowledgeable clinicians to help you on your journey at home with tube feeding. It's imperative that your home care clinician have knowledge of these complications, how to treat them, what sort of recommendations to make to your prescriber, whether it's a physician or nurse practitioner, and then design home care plans that meet your lifestyle needs and meet your clinical needs. And ultimately, for you to have a really good experience on tube feeding and a healthy relationship with your feeding tube. And then this, as promised, this is my final pretty slide for you. And at this point, Andrea, I would like to hand it back to you, and we can field any questions.
Well, thank you, Cynthia. Great presentation. And again, thank you to AVANOS for supporting this educational program. We will now begin the question and answer session, and we encourage you to ask your questions. So if you haven't done so already, feel free to submit your questions in the questions section of the toolbar on the right side of your screen, and we'll do our best to answer as many questions as possible. Okay, we have some coming in now. Cynthia, an attendee asks, does insurance supply more than one gravity feeding bag per day if they do 3 gravity feeds per day?
So that's a great question. And so customarily, what we generally see is 1 bag per day, whether it's a pump feeding or a gravity feeding. So 30 bags a month is generally what you will be provided, regardless of how many gravity feeds that you do in a day. And that's different than maybe an experience inside of a hospital where they may get a new bag for each feeding. But in home care, it's completely appropriate to wash and reuse, to rinse and reuse. And so I don't know that you would receive more than 1 bag per day from your provider.
Okay, great. Okay, what degree of discoloration and blackening of G-tubes is normal?
So is this on the balloon that I was talking about, or are you talking about the dangler part, that like the actual feeding tube that is outside of the body?
They did not specify.
Okay, well, I'll speak to both, but if whoever asked that question, if you want to get in there and put more information in for us, let me know. But I would say on the dangler portion of the tube, or if you're using extension sets, no amount of blackness is tolerated. So if there's any discoloration or blackness happening on the feeding tube, it's time to get it changed. And so I would advocate for an appointment to get that replaced. If we're talking about the balloon, like I showed the discoloration of that balloon, and that's just staining from GI contents and bile acid in medications, or if somebody's putting coffee through their tube, there's lots of things that could stain that, and that's totally normal. The important thing is that the balloon is intact, and that it's properly inflated and holds the water that it's supposed to have. That's the important thing. If it gets discolored, that's not really an issue. But outside, it's a problem. It implies that there's something in there that shouldn't be in there.
Excellent. Next question we have coming in is, any recommendations for best tube securement devices for danglers? Do you recommend tube feeding belts?
So we do have cases where that's a great option. So a belt, or there's some mesh wraps that you can get online that is sort of a softer option, but I think those are really great options for danglers that are just sort of getting in the way. I would maybe evaluate your situation and make sure that your tube is not too long. I have seen cases where people have to like loop their tube around in a big circle and hold it down. If you've got a peg tube that's adjustable, meaning you can take that port out, or that your physician can remove that port out of the end, and it can be cut down and made shorter. So that's something to keep in mind if you've got a tube that's adjustable like that. If you have a balloon gastrostomy, do not cut or take anything off of it. It actually won't come apart. But if you have a tube that is the length that you want it and it still needs to be restrained, then belts are great. There are a variety of different tube securement devices that sort of adhere to the skin, and then you can lay the tube down, and then there could be Velcro or sort of a sticky adherence, and sort of keep things down against your skin. That's an option as well. But if you don't want to have to peel something off of your skin every so often, those belts are a really nice option.
Great. We did have a clarification on what degree of discoloration and blackening of G-tubes is normal. That was for the dangler part.
Okay. Yeah, I would say I have zero tolerance for any black discoloration on your tube. It's time to get it replaced. And if your physician gives you any pushback, push back harder. Because I've had that happen where they were like, no, your tube's fine. But I disagree, because if it is mold, and it very likely could be, that mold, it's safe to feed through it. It's not a great thought to think that you're feeding through a moldy tube, but you can, because they're patent and you can use it. That mold has become embedded into the tube, so it's not coming out of there. But what it does is it begins this process of drying out the tube. It becomes one with it, dries it out, and then eventually that tube will crack and it will fail. And of course, Andrea, it will crack at 10 p.m. on a Friday night. Right?
Of course it will. Okay, next question we have are, what are some examples of barrier creams?
So there are lots of options. So over-the-counter options are the easiest ones that I recommend. So like oh God, I'm having a name recognition problem right now, but like any diaper rash ointment or zinc oxide that you can find over the counter, it could be your store's generic brand, would work just fine. And then of course your home care company may have some options available that are sort of like medical branded Cavalon. There's lots of different brands out there.
Okay, so something like Bomex or Desitin or things like that?
Desitin was the word I was trying to find. So yeah, exactly.
Okay, perfect. Another question for you. I work with ALS patients and need to introduce the idea of PEG early, often, very soon after diagnosis, unfortunately. Any tips for how to introduce PEG gently?
I think that is such a great question, and it's something that I have encountered as a clinician, whether it's like a head and neck cancer issue or ALS. And ALS is extremely important to get that started early, because any weight loss, as you know, just hastens the progression of the disease process, right? So you want to get nutrition support going and have the access available early and not have it be an emergent issue. And so my word to the wise with this for the clinicians on the call is, from the patient perspective who has no exposure to what tube feeding is, like we throw these words around like feeding bags and tubes and all this stuff, like we don't think twice about it. But for somebody who has no idea what we're talking about, I think their perception of what tube feeding will be like is that it's going to be like a colostomy bag and this thing that sort of hangs off of them and they carry around, and it can be very scary and intimidating. So what I recommend is sharing video. Like, for example, what we will do is we have these links on our website that show patient education videos, basically, that show a patient doing bolus feeding and gravity feeding and pump feeding and cleaning the tube site and sort of life with a feeding tube. And what it does is it demystifies it. And I think showing them pictures and educational material that shows what the tube placement looks like, and how simple the design is of the anatomy, and then how it can be removed. And when it's removed, usually ALS patients don't have tubes removed, but for others that do, when it's time to remove it, it's a very simple process. And that hole will close up. And so I think education is the main thing that I would recommend for somebody that is going to wind up on this path. I think the earlier you can educate and demystify, and maybe even connect them with other patients that are on tube feeding, I think that could go. And that's what the Oley Foundation is. And what I love so much about the Oley Foundation is it connects people, and they can share experience and not feel alone in this whole journey.
Excellent. Cynthia, do you recommend patients adjust their own bolsters if it's too loose, or is that reserved for doctors only, or home care RNs or home care RDNs?
That's a great question as well. And the answer is it depends. So if somebody has a very mature stomacyte and they've been home and they've been educated and shown that bolster actually moves. Some people don't even realize that bolster will slide up and down the tube. I think proper education, a healthy stomacyte, and some comfort with their device is critical. If it's in the first 2 weeks of that tube placement, in many cases, I mean, that stomacyte's mature in 2 weeks, but most doctors won't touch it or replace it for 6. So if it's in that time frame, I would work very closely with your physician. If you have a mature stomacyte and this is sort of like no big deal, you can absolutely make adjustments on your tube, and you should. So for instance, if you're gaining weight, because you had lost weight before and this nutrition support is doing its job, you're going to need to pull that bolster back because you're going to gain a little bit of girth, and that's a good thing. If you're having problems with compliance or you were hospitalized or sick and losing weight for some reason, then you're going to need to pull that bolster in tighter, or it's going to be too loose and it's going to leak. So the answer is it depends, but I would make sure that you understand how to do it, and that and have some training and a support system around that. And that can be somebody sort of coaching you over the phone or somebody that comes to visit you. It just depends on your situation.
Okay, looks like we have time for maybe one more question. Is there a standard time that a tube should be replaced yearly, they're asking?
Oh, that's such a good question. I have seen it all. So I have seen the best case scenario, which is a very involved healthcare team and somebody who goes in quarterly and proactively has their tube replaced. Could be every 3 months. It could be every 6 months. It depends on what their protocol is. If the tube is patent and working and clean and not black like the other person was, you can keep it in there. There's really no reason to replace it. And then I've had others that were in there for several years and they were just fine. So if you have any indication that that tube is beginning to fail or is turning colors and it's not, proper flushing is not helping that, then you should get a new device. And if you're having problems with that balloon maintaining the volume, then you should have it replaced. So that was like, it depends. That's my answer.
Excellent. Okay, well, we have run out of time for questions, but we will post answers to the rest of the questions on our Oley website. Now, this is a page on the Oley website where you can find all our resources pertaining to home tube feedings, including past webinars, video library, troubleshooting guides, articles, and consumer patient stories, and much more. So we would like to give a big thank you to Cynthia for the excellent presentation. We appreciate you sharing your expertise with us. And many thanks to AVANOS for supporting this important educational program. Thank you also to participants for joining us. We'll post a recording of the presentation on the Oley website in case you'd like to view it again and again and again. We hope you'll join us for another webinar. To view our schedule of upcoming webinars and past recordings, visit the Oley website at oley.org/webinars. That's it for today. Thank you all. Have a great day and goodbye.